katoa. Ka mihi o ki nai tuahuriri, te mana whenua o tēnā i rohe. Tēnā koutou, tēnā koutou, tēnā koutou katoa. A very warm welcome to this University of Otago Midwinter Symposium. I also greeted Nai Tuahuriri, who are the people of this area. My name's Vicky Cameron, and I'm Deputy Dean of the University of Otago, Christchurch. Many of you might not even realise that the University of Otago has a campus right here in Christchurch with around 1,000 students. Of these, just over 300 are medical students in their final years of clinical training, and we also have around 700 postgraduate students studying for Masters or PhD degrees in the area of health. This evening, we are very fortunate to have 4 Otago academics who are experts in the field of mental health. And 3 of these 4 experts are from our campus here in Christchurch. We're also very fortunate to have a wonderful MC for our panel discussion, so I will now hand over to the erudite, eloquent and entertaining Joe.
Oh, that's right. Hello to you all. Thank you for coming. In the unlikely event of an earthquake, this room is designed to fall slowly, so make your way to the car park with your drinks, all right? The loos, well, you're not going to need them until the end, and then you're on your own, so I'm not even going to tell you where they are. You've been able to find them for 50 years. That's it for housekeeping. You're not going to hear very much from me, because you can feel a sort of pulsing in the room, can't you? And that's the throbbing of these academic brains, all right? And there is a vast reservoir of academic knowledge here on the subject of mental health, and my job is merely to be the conduit between you and them, all right? I am the lubricant in your intellectual congress, if you like, and it's a privilege to be that. Each of these 4 luminaries is going to speak for up to 10 minutes. If there are any absolutely thumping, burning questions immediately after each speech, then we can deal with those as they come. They've got to be absolutely pertinent, instantaneous, have to be dealt with now for maybe 1 or 2 minutes after speech. If there's no questions, don't feel obliged to ask any. All right? 4 speeches, in theory about 40 minutes, and probably go for about 50. Then we open it up to the floor. All right? And we should have at least half an hour of to and fro from the floor. Can I remind you that your job here is to ask questions rather than to make speeches. Their job is to make speeches and answer questions. So from the floor, questions, short, hard, direct questions, and we'll see what happens. And then after that, there'll be refreshments and free food and free non-alcoholic drinks and ludicrously expensive alcoholic ones. And but we'll deal with that when we come to it. All right. So we'll be here for an hour and a half or so. And my first speaker is a professor in the Department of Psychological Medicine at the University of Otago, Christchurch. He works clinically in the Consult Liaison Service at Christchurch Hospital. His general subject is community measures of mental health and matters arising therefrom. Please welcome to the podium Professor Roger Mulder.
Well, thanks very much for coming. You probably wonder why I'm speaking first. It's because I didn't attend the planning meeting. And so that's my job. So I'm going to talk a little bit about our mental health workforce and what we're doing and what's happening to mental health measures in the community, and come up with some ideas of how we might do things differently. So I want to start off by saying that the mental health workforce overall in New Zealand is well trained and is very committed to patient welfare. Most people belong to professional organisations. They encourage continuing education. They monitor performance, and in general, I think, compared to internationally, our mental health services are good. We also have some more consumer participation now, so that's an improvement, and our mental health funding has risen, so it was 1.1 billion in 2008, and it's now 1.4 billion. The number of psychologists and psychiatrists has doubled in the last decade. You may or may not think that's a good thing, but that's what's happened. We've got a lot of people taking drugs. So we got 1 in 7 people are taking antidepressants or were prescribed an antidepressant in 2015. and 1 in 30 people were prescribed an antipsychotic in 2015. So in both of those rates have increased by 50% in the last decade. So we have a whole lot of people apparently getting treatment and things, but then when we try and measure how the community feels in terms of their mental health, it doesn't actually look anywhere near as good. So if we take a measure, there's a measure of high psychological distress, I won't go into what it is, but basically it's gone up 50% from 2011 to 2016, where it says 7% of New Zealanders are significantly unhappy. The number of children with psychiatric problems has doubled in the past 5 years. There's been a 4-fold increase in people going on to disability benefits due to a mental illness in the past 15 years. And I don't have to talk to you about the suicide rate. So we've got this slight contradiction. We've got this well-committed, well-functioning mental health workforce, but we've got this unhappy community. And one of the nice things about it is not just us. All right? This is throughout the so-called high-income countries. So there's a study done where they looked at Australia and UK, USA and Canada, and they're all just as miserable as us. And in fact, the USA is more miserable than us, and more miserable even now in the last year. As you might find, they're probably more miserable today than they were yesterday. So there's been this ongoing thing with, and especially English-speaking countries for reasons I don't know. So what's going on? I mean, if mental health treatments work, well, why aren't we all feeling mentally healthier? We should have fewer people in crisis, less people on disability benefits, lower suicide rates. What's going on? Now, we know from randomised controlled trials that our treatments seem to work for individuals, but they don't seem to be working at a community level. Are we not giving them to the right people? Are we giving them too late? Are they not good quality? Would we be even worse off if we weren't treating these mental health problems? So we don't really know. There is evidence that treatment's poorly targeted. For example, a study said that 65% of Americans getting treatment for mental disorder in one of the United States health organisations were not actually mentally ill. It seemed a bit odd. So they were getting, lots of people are prescribed drugs who aren't mentally ill, and lots of people are given treatments who aren't. So we don't know. So how long have we got? About halfway through. So good. Okay, so what are we going to do about it? So what a lot of people have said, well, we need a new strategy. And I think that's true. We can't just keep doing what we're doing. Otherwise, we're all going to be on antidepressants by 2050. And half the population will be treating the other half of the population. So we really won't have anyone doing anything productive. So we do need to look at other things. And what are the things that seem to determine whether people are happy or unhappy or mentally ill? Well, it's quite easy, and I'm sure you all know this. The major things that determine it are adverse childhood events, which I think are going to be discussed, so bad things happening when you're children, poverty, inequality, all the things that we think cause it actually do seem to have a powerful effect. So we looked at a study, New Zealand has this wonderful measure of how you're going, a deprivation index, all right? So if you're the most deprived people in the bottom 10%, they looked at how unhappy they are, and not surprisingly, a quarter of them were unhappy. Now, if you're in the top 10%, less than 1% of you are unhappy. So the best way to become happy is to become less deprived, which seems very obvious, but it's quite hard to become less deprived by yourself. So I think we've also looked at things such as inequality in countries, and there's a line like that, which is between people who have income, where countries have more unequal incomes versus mental illness. So we do know that some things can be done at a community level. I work in the Cook Islands in Samoa. They seem to have lower levels, although we don't quite know, of mental distress. Now, they're a much more connected society. I've never seen a patient in Samoa by themselves. There's always someone with them. So, what do we need to try and do? Well, I don't think we do more of the same. I think at a service level, we do have to try and ensure our treatments have evidence and they're targeted optimally. Patients should receive treatment that's evidence-based. There should be clear outcome measures. New treatments need to be evaluated. And I think there'll be a theme here as well. We don't actually have much money to research new treatments, especially psychosocial treatments. We need different ways of managing mental illness. And we need support from the Health Research Council and other places to look at evaluating the efficacy of that. At the next level, we could argue, given adverse childhood events are so important, we need to look at interventions designed to enhance parenting skills, promote healthy child development, broaden public and professional understanding of the links between adverse childhood experience and later mental health experiences. Clinicians should inquire about people's life experiences, inquire about what happened and try to avoid re-traumatising them. So we have a sort of service level and an individual level and another model of looking at people. And at the same time, I think we need to actually normalise some psychological distress as part of life and not encourage everyone to go to a mental health professional because they're distressed. It might be a lot better to talk to your friends, or as Joe would say, have a few drinks, than to necessarily go and seek professional help. However, we also need a society where heavy drinking is not normalised and where the price and access to alcohol is restricted. And I think at a broader level, and this is a really interesting problem, this is what the politicians don't want to hear, we need to consider whether increasing inequality and poverty is actually one of the major drivers behind the fact we're all getting more unhappy, and just giving everyone pills and giving everyone treatment is not going to be of any use. It's much easier for a government to promise more mental health services than to say we're going to redistribute income, which is probably the single most effective way of actually improving mental health in a community. So, to finish, New Zealand's a small country, they've got a small population, and therefore you can argue, we could be courageous in tackling the problem of increasing psychological distress in the community and increasing suicide. This problem is not just ours, it appears to be shared among all our high-income countries, especially those with individualistic and competitive philosophies, which we tend to have. So trying to turn this around is a major challenge, but I think we really do have to look at much broader ways to tackle the mental distress in our community. So thank you.
I think I would get universal agreement by saying both frank and fascinating. No, it really was. I just want to ask one question. Is it possible that simply asking reveals vast amounts of mental unwellness? That simply asking the question, because you say you doubled the amount of psychiatrists and lots more people are sick.
It's an unfortunate coincidence, but actually, no, I mean, there's some evidence here we are more prepared to say we're mentally unwell, but the Australians have looked at this quite closely, and there's not good evidence that that's the only reason. We actually do seem to be more mentally unwell. So I was just saying before, a study I read today, pregnant women in England in a birth cohort are 50% more likely to be depressed than their mother was while having a child. So something's...
But did they ask their mums?
Yes, no, I mean, seriously, they asked the same question to their mums. Now, their mums may not have wanted to admit it.
My mum would never have said,
Well,
yeah.
you could argue that, but that's slightly convenient argument.
Right.
I don't think it explains it.
Base all theory on my mum. Any absolutely burning, short, pithy, right now questions, or do we move on to the next speaker?
Next speaker.
I'm liking the tone of this. The next speaker works as a primary care doctor specialising in adolescent youth health at a community youth health centre for 10 to 25-year-olds, which she helped set up. Please welcome to the stage, speaking on the subject of adverse child experiences and their ramifications, Dr. Sue Bagshall.
Well, Roger's pitched everything I was going to say. Tēnā koutou, tēnā koutou, tēnā koutou katoa. Yeah, I sometimes actually introduce myself these days as a youth worker with a medical degree. Because actually I feel much more like a youth worker than a doctor. I teach medical students and I undermine their approach to medicine because I tell them not to look for risks to fix and illness to fix, but to look for health and try and grow it. Which the medical model, it's getting better in terms of only looking for illness to fix. But the one thing I'd like to leave you with and to go home with is the difference between mental health and mental ill health. The number of times I've had somebody say to me, oh, she's got mental health. And I go, oh, good. I understand why we call it mental health, because there's so much stigma, discrimination, historical stuff in our culture that says it's bad, it's evil, it's weak, it's whatever. But wouldn't it be great if we could actually talk about mental ill health? Because now we can talk about cancer now much more freely. But wouldn't it be great if we can talk about mental ill health? And then we can actually focus on what is mental health. And then maybe we could grow some mental health instead of all being miserable. So that's what I'd like to leave you with mostly. In terms of young people, certainly if you measure rates, it's gone up, suicide rates going up, we know all about that. Anxiety is going up. And whether it's certainly we've observed, particularly since the earthquake, an increase. But whether it's the earthquake sequence that has actually caused that, or whether it's given us permission to come forward. Because certainly, interestingly enough, with the Youth One Stop Shop before the earthquakes, we had no parents come in. Now, almost every young person who comes in got a parent with them, which I think is great, because I think it's really good that parents are concerned about their young people. But at the same time, it's an interesting kind of fact that we are being given permission a bit more, that's really good. But as Roger said, are we making any difference? I think if we can actually start focusing on mental health, then maybe we could. But the one thing I've been observing recently is the increase, or maybe it's my observation and my increasing awareness of adverse child experiences. And actually, I date them back to the wars. Because after the First War, what happened, people came back and it was called shell shock or whatever it was called, but it was a sign of weakness. You were a bit of a weak soldier if you came back not really coping afterwards. But they then brought up children with moods that were going like this, partly because all that trauma. But it's really hard to be brought up by a parent when you don't know where you stand and you don't attach properly because their mood's going up and down like this. And we know that often emotional trauma in childhood leads to fluctuating mood. Now we can call that bipolar or depression or anxiety, or we could call it a normal response to an adverse child experience. We also know from the research that adverse child experiences cause damage in the brain. We know that the brain's beautifully flexible and we can repair that, which is good news, but it causes some damage, which if it isn't repaired and given some opportunity to do that, then it can cause problems in adulthood. So the San Diego study, which this is all kind of came from in a way, was a study of 17,000 Americans. That was back in 1990, so perhaps they weren't so miserable then. But what they found was in this 17,000 white middle-class Americans, no blacks, no poor people, no Latinos, only a third of them had no adverse child experiences. And that's things like being a victim of all the kinds of different abuses, neglect, or witnessing, or having a parent in jail, or a parent with a mental illness or an addiction. So this cohort, if you like, has been followed up. And what they found is that not only do they have an increased risk of mental ill health, they have an increased risk of physical ill health, heart disease, strokes, high blood pressure, cancers, and early death. So if we could do something to intervene with these adverse child experiences, maybe we could do something about all the money that's spent on physical and mental ill health, never mind the suffering that people go through. But the question is what to do. And with Roger here, we need to change our society in terms of helping those people to heal when they've had trauma. And actually create an environment of acceptance, create an environment of decreasing discrimination, celebrating diversity, and create an environment where bullying is not tolerated. And it's not just in schools, it's everywhere. And children and young people are just reflecting what they see adults do. And bullying, what is it? It's just power, isn't it? The abuse of power, if you like. So it goes against anybody who's different. But actually, aren't we all different? And maybe looking at those kind of things might be much more effective than medication and all that kind of stuff for increasing mental health. There's still a place, I think, for all the treatments for mental ill health, but let's define that a bit more clearly so that we actually know who we're trying to help. And maybe if we get more idea of the adverse child experiences out there and understand them a bit better and understand what can prevent that, which I think is all the things Roger said in terms of more equal income and all that kind of stuff, then maybe we could get somewhere. I just want to invite of youth suicide, which is really making the headlines all the time at the moment. Quote Susan Stephan, who's an American researcher, and I thought it was just a brilliant quote in terms of the efforts we're trying to do to prevent suicide. As a society, we see preventing suicide as analogous to snatching a person out of the way of a speeding vehicle. We don't see it as walking along the road with a person who's completely lost and uncertain about his or her destination, when we don't know the destination either. It may be a long way away. The person may never get there, but the walk alongside is the process. It's how we stay alive. I think I'll finish there.
There's going to be provocative variety this evening. Splendid. So any burning questions? I've got one. Sorry, you're warm. I was talking to a vet the other day, and my dog's nature was entirely changed by the earthquakes. And he's not lying. He went from fearless to timid and scared by minor noises and all sorts of things, from being a dog that was literally unfazed. And this vet was telling me there was an entire cohort of dogs of roughly his age that are neurotic in their old age. And that's not really a question.
What I would add is that that's exactly what we're seeing in primary schools now.
Right.
An increase.
Do they bark?
No, they hit each other and shout at each other.
Really?
There's a real increase in angry, if you like, interchanges. And that's an expression of anxiety as much as anything. So yeah, we're definitely seeing this coming through.
How do you know that?
Teachers have reflected it, and there's been a study amongst about 5 different primary schools by Catherine Liberty from the University of Canterbury, who's kind of done some observations.
Okay. Splendid. Thank you very much. Right, our next viewpoint, ladies and gentlemen, is from oh my God, a question. The evening has taken off. Yes, ma'am. I'm sorry, we've got no microphones out there because we've only got 2 here. So you have to speak loudly and I'll rebroadcast it.
Right. I just wonder what facilities we have in Canterbury or in New Zealand for abused people who come forward to abuse child abuse, and as adults, so people who would be the children of people that come back from the war. Because I'm one of those people, and I found it very, I was both sick and very sensitive.
The question was for those at the back. The question was, what facilities are there for people who are suffering, for example, as children of those who come back from the war, who are presenting as adults? Is that a fair reflection of your question?
That's a very good question. The psychiatrist here might be able to say, but at the same time, I think if you're ill, then there's somewhere, but the trouble is when you're not really ill, you're suffering from trauma, that there isn't very much. Well, this is the hard part, isn't it? Because the trauma sometimes leads to illness, but sometimes it doesn't. Yeah, and it's really hard to know. Yeah, that's right. That's why I think it's best not to blame things, but actually to say, well, what's happening, what's contributed to how I'm feeling right now, and how can I surround myself with the good stuff I really need. If you're interested in some research done on different therapies for different traumas, there's a book called The Body Keeps the Score, and it's the 30-year summary of Bessel van der Kolk's research into various treatments, from acting as Shakespeare play through to deep down interpersonal psychotherapy stuff, and everything else in between. So I think and it's round about just getting the treatment that suits the person.
Great, thank you. All right, next speaker is the Professor and Head of the Department of Psychological Medicine at the University of Otago in Christchurch, and also a consultant psychiatrist in the Service for Adults with Intellectual Disability. His subject is, he's very keen to do it, antidepressants and the spectrum of depression and matters arising therefrom. Please welcome Professor Richard Porter.
Thanks, Joe, and thanks everybody for being here tonight. Now, I'm going to talk about a much rehearsed subject over the last number of years, and in fact this was controversial 20 years ago when I started training, and that's the issue of the prescription of antidepressants in modern society. Now, in New Zealand, as Roger's already said, in 2015, 1 in 7 in the population received a prescription for an antidepressant. That's a very high number. It actually isn't the highest amongst developed countries. It's the 8th highest in the OECD, so it's not an issue that's unique to New Zealand. And of course that figure and that issue provides a fertile ground for controversy and for argument. And of course it also is a subject in which there are very opposing views. So at one end of the spectrum, for instance, the pharmaceutical industry, if they can perpetuate a situation in which a 1/7 of the population is prescribed an antidepressant, there's a lot of money to be made. At the other end of the spectrum, you have the anti-psychiatrists, and indeed sometimes maverick psychiatrists who see a role for them going around the world, and New Zealand recently talking about this issue and saying essentially that antidepressants don't work. Of course, people with extreme views usually promulgate those views by simplifying the situation and making a very complex situation as simple as they can. And what I want to do in the next 6 or 7 minutes is to unsimplify this. Of course, it's such a complex issue that I will end up simplifying it to some extent, but I want to make it a little less simple. And I think what I'll argue at the end of that is that, in fact, the controversy shouldn't be about antidepressants, but it should be about what the alternatives are and whether they're available, in fact. So to do this, I'm going to just invent a hypothetical patient and give you some scenarios and talk about what perhaps should be the standard treatment in those scenarios. So we'll talk about a hypothetical 45-year-old woman. We'll call her Megan, because that's the sort of name of the year, really. And she works for a bank. She works for an Australian bank, and things have been a bit stressful because they set targets for her to sell unnecessary insurance products to her customers. She's also had a bit of stress because her mum had breast cancer. She's recovering now, but that's clearly been stressful. So in scenario 1, Megan goes to her GP. She's been feeling a bit down for the last 3 months, just not quite herself. She's been feeling anxious, wakes in the morning worrying about these targets at the bank. Come the weekend, she's actually really good. She enjoys contact with her teenage kids. She enjoys the sport on a Saturday morning. She's sleeping okay, maybe a couple of nights sleep in the last couple of weeks. She's not been so good. And she's presenting it to her GP because she feels somewhat low. Now, I think if you asked 100 GPs, 100 psychiatrists, 99 of them will give you the same answer. That Megan doesn't need antidepressants, and in fact shouldn't be prescribed antidepressants. This is a mild, stress, depressive, whatever you care to call it, reaction. What it needs, we're not entirely sure, and in fact many people like Megan will get better spontaneously. GP practices, primary health organisations have a service called the Brief Intervention Service, which gives 3 to 5 sessions of counselling, some basic level counselling. That may well be helpful for Megan. So that's scenario 1. Scenario 2, same woman, but she presents to her GP instead with, she's really actually quite low. She's been low most of the time, or a lot of the time for the last 3 months. She's anxious about her targets at work. Every week she would have 2 to 3 nights when her sleep is quite significantly disturbed. still enjoys things, but she's certainly not enjoying her teenage children quite as much as she used to. A number of reasons for that, possibly, but she also, a number of Saturdays in the last few months, she's not gone to Saturday sport. She just can't quite face it. So she is presenting really quite a lot worse than the previous scenario. So what's the appropriate treatment in this case? Again, I think you would get a reasonably clear consensus amongst clinicians that there are 3 appropriate treatments. One is to prescribe an antidepressant. The second is to refer Megan for an appropriate course of psychotherapy, 10 to 12 sessions of a specialist psychotherapy with a skilled therapist. And the third option is to do both. And possibly that, the evidence would suggest, is slightly more effective than either of the other 2. And how would they decide that? Which of these 3 options she would take? Well, that should be decided by the GP discussing with Megan those 3 options, the pros and cons, and what Megan wants at that particular time, and coming to some sort of conclusion. So that's scenario 2. Scenario 3 then, Megan presents to her GP. She is really very, very depressed. She's feeling absolutely dreadful. And it's pretty much the whole of the time. She hasn't been to work for 2 weeks. She just got to the point she could not do it. She hasn't been out to Saturday sport for 3 months. She barely talks to her children. She just sits there essentially. She wakes up at 4 o'clock every morning thinking about how useless she is. She's got some suicidal thoughts. So what should the GP do in this scenario? Well, treatment should include an antidepressant. There's no doubt about that. It should probably include some psychological treatment as well. Maybe referral to specialist services. One point I would make is that the group of Megans who are mildly depressed is vast. The group of Megans who are moderately depressed is smaller, and the group of severe depression is very, very much smaller. So in an ideal world then, a relatively small proportion of people would get antidepressants. So what's the problem then? Well, let's think about mildly depressed Megan. Of course, GPs are limited in their time, 7 to 10 minutes for each consultation, and a real imperative to turn people over and get them in and out quickly. So does the GP have time to tease out the fact that this is a mild, probably self-limited depression? And what is the availability of those brief intervention services? When they started, people get to see them quickly, but now most of them have waiting lists, and they're urgently looking for ways to actually get through the demand, which is, as Roger said, really quite great in the community. Second scenario, the moderate depression. Who does the GP refer to for psychological therapy? Actually, specialist psychological therapy for depression in New Zealand is not available to all intents and purposes. So there is not that option available. So what can the GP do other than prescribe an antidepressant? Option 3, again, the psychological therapy is not available, but Megan probably will get to specialist services and get roughly the appropriate treatment. So the controversy isn't really at the root cause the prescription of the antidepressants. The controversy and the problem is 2 things. Firstly, the availability of other treatments to treat depression appropriately in New Zealand and in many other OECD countries. Secondly, we don't always know exactly what type of therapy to give in what situation in the New Zealand context. And as Roger mentioned, the major health research funder, the Health Research Council in New Zealand, in the last 10 years has funded 4 psychiatric projects. That's in the whole of New Zealand. So we're really lacking in the availability of alternative treatments to antidepressants, and research is very limited. And that is what the controversy should be, and not the prescription of antidepressants, which is the outcome of this problem. Thank you. I'm aware I haven't talked about Joe's dog or his mother, but let's wait and see what's happening.
Oh, very good. Thanks. All right. Thank you, Richard.
for $100 US, you can have a genome mapping, and then from that, there's the hope that targeted medication, rather than something a bit more blanket, is going to occur. Could you comment on that? Yes, I think there's the hope that targeted medication will occur, but it's not, or that time hasn't arrived yet, and it will be a long way off. Sure. Possibly not in your lifetime.
Is that internationally?
Yeah, internationally. So there is no genetic test that tells you what medication would be appropriate at this point. There might be, but it's a long way off.
Joe, do you mind if I throw a question in? So one of the things that's come up in the last 15 to 20 years has been the availability of internet psychotherapy. Do you think that that's I hear some chuckles in the background, do you think that this is an alternative, or that it works, or it's viable?
I think it's potentially an alternative in the mild group, that it may be helpful for people to engage with these internet programs, and it could be quite helpful, but I think there is no evidence at this point for moderately severe depression, and the moderately severe scenario that I described, and I think that requires human input and expert clinical input. And a lot of people, internet treatment systems, many people don't get through very many of the sessions on those systems. So particularly if they're severely depressed, it's very important to maintain the motivation.
It's quite a good game called Sparks for sort of really 8 to 10-year-olds to teach them kind of ways to get around coping with stress, basically. And that's been shown to be fairly effective for the milder people. I wouldn't recommend it to anybody who fancies themselves as a gamer. They just go.
Can you comment on exercise?
Yeah, there is some evidence for exercise as a positive intervention in depression. And I think, again, in the mild situation, it's something that GPs would recommend and help with the green prescription, etc. It's probably helpful in all types, or the whole spectrum of depression, but it obviously gets harder to maintain an exercise program as you get more severely depressed, and so that's where its limitations are. There are many lifestyle changes that are highly likely to be helpful, but with all of them, as you get towards this more severe end of the spectrum there, the practicality gets much less.
What about artificial intelligence for diagnosis? That seems to be increasingly useful in medicine.
I think it's going to be a long time before artificial intelligence becomes a useful tool in psychiatry, because it is so complex.
When you talk about specialist psychotherapy, Richard, what do you mean?
There are a number of psychotherapies that have been tested and trialled in proper clinical trials in depression, so cognitive behavioural psychotherapy, interpersonal psychotherapy, and there's a few others as well.
So you're not necessarily talking about someone who's a clinical psychologist or a practitioner?
Not necessarily, but once you get beyond the mild depression and you're looking at a course of 10 to 12 sessions in most cases, then you are getting to a higher level of expertise. So it wouldn't necessarily be a clinical psychologist, but the training to deal with that level of severity would be longer, and the level of expertise higher.
One more, and then we'll move on to the final speaker, and then we'll have any further questions after. Yes, from you, then.
Oh, I was just asking, what was the waiting time for an appointment with any of these specialists?
Well, I think
Somebody not of me, or somebody in the public.
the waiting time to see a psychiatrist in the public system, or to see the services, is very short, because that's the way the system's set up. The only problem with that is that then leads the public system to have a cut-off of severity, which is really quite severe, because because otherwise they would end up with a great long waiting list. The waiting time for, essentially there is no public system for specialist psychotherapy, so the waiting time is forever.
On that cheerful note. Thank you very much. I think the big Q&A session here is going to be spectacular, and I'm looking forward to it. Our final speaker, hovering on my right shoulder, is the Buckland Professor of the Dunedin School of Consultant Psychiatry. He is a consultant psychiatrist. He is going to address you on the subject of next generation antidepressants and other therapies. Please welcome Professor Paul Clune.
Thank you all for coming out. There are much better things you could be doing tonight, but this probably is at least reasonably up there. So a couple of things. As well as doing research, and I'm just going to talk about research topics tonight, I work in an acute inpatient unit. And in practical terms, once we've seen patients, I'm very happy to use medications, to use social arrangements to try and get families to be involved with treatment. We do have access to various types of psychotherapy. In our community teams, it's about 3 to 6 months for someone referred there to get access to a psychologist. But it is, as Richard was saying, it's a really scarce resource, and one that we would do very well if we're trying to increase availability of expertise to look at. So that's the daytime job. The research I'm doing, I'm going to look at 2 topics. One is antidepressants or anti-anxiety drugs that work really fast. So if any of you were to come down with a severe case of depression and your GP says, I'm going to put you on some Prozac, the chances are that it will take 4 to 6 weeks before you see some sort of improvement. And even if you go through a couple of cycles of antidepressant, there's only about a 2 in 3 chance that you're likely to respond. And if we focus on the severe depression end of the spectrum, we've got a large group of people who are very unwell, who haven't responded to treatment. You might go for adding lithium in, adding antipsychotics, cocktails of drugs, ECT, various sorts of psychotherapy thrown in, and they're still stuck with this horrible depression. About 20 years ago, a group in Connecticut were looking at the effects of ketamine in different patient groups, and one of the groups they looked at was patients with severe depression that hadn't responded to treatment. And to their surprise, when they infused 0.5 milligram per kilogram over 40 minutes, these patients, 8 or so patients with depression that hadn't responded to anything, about an hour or so later said, my depression's gone. And it remained that way for 24 hours, 48 hours, 72 hours, and the experiment stopped at that point. They hadn't assumed that the patients would actually show any improvement. So there was the sense of, okay, you responded, how long is it going to last for? So over the next 5 or 6 years, a replication study came out, and what they showed was that about 2/3 of these treatment refractory patients show a response, kicks in within the first hour. Most people last to 3 days, a few people last to a week. Within a couple of weeks, everyone's got their depression back. And so there have been multiple replications. We've got 5 randomized controlled trials. We've got about 500 or 600 case series of patients, and they all show roughly the same thing. We've got some research going on in Dunedin which is looking at patients with depression, but what we found is that actually it doesn't matter what sort of negative mood disorder. We found that ketamine works in social anxiety, so this is fear of public scrutiny, generalized anxiety, so chronic severe worry, panic disorder. Other groups have shown that obsessive compulsive disorder, the post-traumatic stress disorder, all of these respond to ketamine, and it's the same dose response, and it's the same rapid onset within an hour and wear off within a week. So fabulous in terms of treatment options. The problems are we don't know how long to give it for. We've got a sense of what a starter dose is, but we don't know what a maximum dose is. We've been treating patients with anxiety for about 3 months, and at the end of 3 months, about a quarter of them stay well. Most people get their symptoms back within a couple of weeks. So it's possible if we dose them for longer that they may remain well. The other thing that this does for diagnoses is that when we're teaching medical students, we say, this is depression, these are the 5 types of anxiety disorders, never the twain shall meet. They all look the same in terms of response to ketamine. And one of the things that we're trying to understand in terms of why are these drugs working, that there's a personality process that we call neuroticism, and in lay terms, it's the tendency to react to stress by having negative emotions. And it's a risk factor for all sorts of all types of anxiety and depressive disorders, misery, other sorts of things. And it's possible that what ketamine is doing is taking up that bit of that part of that's contributing to your anxiety or depressive disorder. It does throw diagnosis into a bit of a spin, that really what we may be doing is lumping a lot of what before DSM-3 were called neurotic disorders actually back together again, but they all may be ketamine responses. So before you start thinking, wow, ketamine's great, it's scheduled, so it has an abuse liability. It does cause dissociation, so you don't want to take a dose and then go drive in your car. At the moment, there are no approved formulations. Janssen is developing a nasal spray formulation. So sometime in the next 3 to 5 years, there should be a product available on the market with some instructions as to how to use it. But I think it's a very interesting prospect, especially for people with severe depression. I'm not talking about Richard's mild depressives who are struggling because they're not enjoying work. These are people with severe disabling illness, but it certainly offers an option. The second area I want to talk about is looking at brain networks. So if you've wondered how your brain integrates all of its different types of mental activity into being able to understand and manage the world, to plan things, to exercise executive control, to be able to hear and smell and memorize things, all of these involve different networks in the brain, and they're all integrated with a couple of giant hubs at the front and the back of the brain. One of the things we've been looking at is whether not the main networks, but some sub-networks are somehow abnormally activated in different conditions. And we recently were in the process of publishing some work in people with severe alcoholism. And in this case, it's alcoholism associated with extreme craving for alcohol. And what we find is that there's a little sub-network, and I'm going to indicate on my head, that runs between the anterior and posterior cingulate. So essentially a sort of an oval-shaped area of electrical activity that's incredibly hot, and it involves particular bandwidth, so beta waves, for example. And if you switch off those brain waves with magnetic stimulation, you can see a reduction in craving for alcohol. What we've done in the recently completed research is actually put a probe in between the two halves of the hemisphere. So if you think of what the brain looks like, you've got the two halves of a walnut. If you slide a little probe in between those and have a stimulator and switch it on, you can switch off craving. And what we found was people on average went from drinking 25, 26 standard drinks a day, so something like 4 bottles of wine a day, down to 1 or 2 drinks. So the craving goes, and suddenly you've got this extraordinary change in drinking behaviour, and all the social and other consequences associated with heavy drinking disappear. The other interesting thing is it's not just alcoholism. So we've got some preliminary EEG data of people with severe restricting anorexia. So these are the predominantly young women who've been starving themselves for 5 years, and it's really become hardwired. We see the same profile, and in this case, the instead of craving for alcohol, what we're seeing is a form of abnormal salience or attending to things in terms of I'm fat, I've got to lose weight. We see the same profile in people with morbid obesity who have food craving. And the idea is perhaps not by putting probes into people's head, but perhaps by using neurofeedback, ways of helping people to adjust their own brainwave activity, that we may be able to treat some of these at the moment rather untreatable conditions. So hopefully in the next 5 years we'll see how much of this is science fiction and how much of it comes to bear. Thank you very much.
Any immediate questions for the professor from the drunks out there?
Joe,
See you afterwards.
we still have a couple of probes left.
Yes, ma'am.
I haven't had a drink. I
So we, one of the challenges when we start to get in other addictions is often one gets into sort of multiple uses. So for example, someone might be smoking a lot of cannabis and using street opioids and methamphetamine. We haven't looked at that population yet. We've tried to try and pick a relatively sort of pure group, in this case people just drinking large amounts of alcohol. Look, it's a really interesting question because potentially anything that's involved with abnormal salience or attention to things or abnormal appetite could potentially have the same brainwave patterns. Hi. So these are people with shopping addiction or internet addiction and things. I really struggle with seeing these as the same as things like, say, alcohol use disorder. I know that WHO is trying to squeeze internet addiction in amongst the other disorders. One of the challenges we've got with these other things is you don't see tolerance and withdrawal, which is sort of physiological changes or in response to sort of heavily using a drug and then not using it and withdrawing from it. And I'm not sure that you see the same thing with, say going onto Facebook 15 times a day. Or playing Fortnite over and over again. Although it is a really good game. I think that, it's a really interesting question, but I think the jury's still out on how much of these different sort of overuse disorders could you shoehorn into an addiction type pattern.
Well, shall we go to general questioning now? Dr. Paul Bloom. Sorry, I demoted him to doctor. He's a professor. You can sit in the shape of his skull. Right. As I say, sorry that we haven't got mics out there. It's because there's another thing going on in the other room, and we haven't got enough mics. So, if you'd like to pose a question, and I would say again, it's a question time rather than making a speech time, on anything related to anything these people have said that you would like to ask them about, you have the opportunity to probe their cerebella. Now is the time, and we've got half an hour to do it, and don't be shy. Yes, ma'am.
I was just going to ask with Paul, with the ketamine treatment, so for drugs that can take 2 to 3 to 4 weeks to kick in, would you use them like conjunctively? So would you give like the first dose with the ketamine, knowing that it could last a week, but then still keep the fluoxetine or whatever going in hopes that it will kind of catch up? So
Janssen, the people who are making the nasal spray, are actually using that particular design. So it's a way of getting a fast start out of the gate, as it were. Basically, all the people I've seen have been on, half dozen antidepressants. They've all failed, and by the time they come to our clinic, we're not changing their antidepressants. We leave them stable. If they're getting psychotherapy, we keep that stable. But Janssen, I think, one of their ideas for commercialising the ketamine nasal spray is not just as a standalone treatment, but we can start you on Prozac and have you well on the first day, but we're going to continue treating you with Prozac after the first 4 weeks of nasal sprays.
Ketamine is horse drug, isn't it?
Yes, it is.
What does it do for horses? Just
it makes them sleepy. So the reason that ketamine was such an important drug when it came along in the 60s was you can operate on people and it doesn't cut off their respiratory drive. So it came along at the era of the Vietnam War, and you've got someone who's had their arm blown off, and you can operate on them in the battlefield without having to have someone ventilate them. Whereas if you're using propofol or any of the inhalational anaesthetics, you need to keep them breathing.
So but it slows a horse down. It makes it a worse horse.
So if you give a big enough dose, that's right.
Yeah, right. That's all. I want to know if it improved or deteriorated a horse.
It's all about the dose. If you give a low dose, it'll have analgesic effects. If you give about 10 times that dose, it'll put them off to sleep. So you can operate on them.
Does analgesic mean run faster?
No, analgesic means I have no pain.
Right. So it might run faster.
No.
All right, okay.
No, it's,
All right, I'm sorry.
it's going to be wheezy. It's you know, this is not a performance enhancing drug. This is why you don't see the Olympic Games people testing people for ketamine after they've won 100 metres.
So you give it to a horse to novel it.
To slow it down so that you can
To
take
novel,
it,
to novel a horse.
so you can take its gallbladder out or whatever.
Oh, no, I mean, I'm talking about doping it
Oh, yeah.
for racing.
Yes, absolutely.
It would slow you, the horse would come up the blocks and just fall over asleep.
That's right. I suspect people would be suspicious.
Right, okay. Yeah, okay. Sorry, sir.
I'm just wondering how much like a therapeutic dose for depression can be compared to like the dose you use recreation.
So that's a good question. so the standard dose for depression and anxiety is around 0.2 to 0.3 milligrams per kilogram. So 100 kilogram guy, 20 milligrams to 30 milligrams. An effective dose somewhere between half and 1 milligram per kilogram. In order to to achieve what's called a K-hole, this is an intense dissociative experience, you're looking at going around 7 times that level. And to get anaesthetised, you're looking at about 10 times that level. So 7 milligrams per kilogram for a nice K-hole, 10 milligrams per kilogram to get your appendix taken out.
Right, there you go. Yes, ma'am.
Would any of the panel have a comment on the effect of, for publicity, technology on the mental health, obviously, of all of our population now? It seems to me that over the past 10, 15 years we've had a huge increase in the use of cell phones, being extension arms and all of those sorts of things.
So cell phones and the internet is
And
what
all
you...
of that sort of stuff.
Yeah. Anybody?
Yeah, I can comment on aspects of that. Two of the things we've been very interested in Christchurch researching is cognitive impairment in mood disorders, and the other is the circadian rhythm and how it affects mood disorders. So technology, firstly, we're now living in an environment where we're constantly distracted. So people work with their email popping up on their screen, their cell phone going, etc. And I think there's beginning to be evidence that that's detrimental for people's mental health. It's certainly detrimental for productivity. And of course, teenagers now are endlessly distracted by Snapchat, etc. So I think that potentially, I'm not sure it's been well researched at this point, but I think that increased distraction in the environment is potentially really problematic. And for people with mental illness, which is established, and again, we're talking about the severe end of the spectrum, it's clear that people have quite significant problems with memory, attention, etc. And so they're more vulnerable to that distracted home working environment. The second thing to say is that mood disorders, again, are very susceptible to alterations in your circadian rhythm, so when you go to sleep, when you wake up, etc. And of course, having blue light throughout the day, and particularly in the evening, can be a potent source of disruption in the circadian rhythm. You can get apps for your cell phone which stop it emitting blue light after a certain hour of the day, but computer screens, etc., don't often have that.
Anybody else?
I think in terms of developing brains, so the time in life when your cerebral cortex is really linking up with every other part of your brain, it certainly seems to cause more distraction, so they get overloaded more quickly. So there's loads of, for instance, they have loads of friends, but they're internet friends, but there's still loads of friends to actually connect up with, and therefore often those connections that are developing can get overwhelmed because there's not enough there yet. So whether that's harmful or not, I don't know. Whether it actually increases the amount of connections because you're making more connections with friends, I'm not sure. We haven't got enough research yet. But certainly video game addiction seems to be a very real thing. And people forego what they know is good for them in terms of that definition of addiction. So they're still doing it even though they know it's harmful. But in terms of withdrawals, I've certainly seen things thrown across the room as a result of withdrawing from being able to play. But whether that's a physiological one or not, I'm not sure.
Just frustration because you just got shot at the end of the fortnight. So let me add one other little wrinkle on this, and it's a little bit different from what's been mentioned up till now. So we get a lot of teenagers on our acute inpatient ward, and often a very common scenario is they're getting bullied, or there's sort of Facebook harassment, and often that harassment continues while they're in an inpatient setting. And one of the things that we've been pretty strict about is when that's happening, we take phones away, we switch them off, we get people to delete Facebook accounts, because this can be a chronic corrosive element in why young people are distressed and suicidal, and the teasing doesn't go away since, even though they're in hospital.
Yes, ma'am.
So is it considered by psychiatrists or generally known that possibly you can have a generational, like you can inherit it, the depression? Is that a fact?
Is depression heritable? Is that the question? Yeah.
I mean, the short answer is yes. Basically, all the serious mental illnesses run in families to some degree, but the heritability is much more complex than we thought it was initially, and you may not inherit the illness, you may inherit certain propensities and traits, and then what happens in your life interacts with that. It's the usual thing. We thought it was simple, it's more and more complex, but there is part of it is heritable, certainly for the more severe illnesses like bipolar disorder, schizophrenia, and recurrent major depression.
I'm thinking of a relation that grandmother committed suicide 10 years ago, and then the daughter ended up in Sunnyside for 18 years, and it seems to come down to the next generation and the next son.
Certainly some of the effects of adverse child experiences seem to interface with genetic stuff. It seems to be reversible as well, but certainly there's that link in addition.
Thank you. Yes, ma'am.
I'm really concerned about young people and anxiety. So what are your theories? It just seems to me that most teenagers that I come in contact with have anxiety. What do you think, apart from the earthquake theory, could be added to that?
So can I just ask you say that you come in contact with just normally socially or professionally? May I ask what profession?
I run a program for young people that have had mental ill health that are looking to continue life, work or study.
Thank you.
And I'm the firm hand behind the back, non-clinical.
So the question is around anxiety in young people. It's a really complex issue. I think part of the issue is we call worry anxiety now, whereas it used to be worry and concern and not sure about things, and now we call it anxiety, which kind of medicalizes it a little bit. So that's the hard part. I think in terms of coping with stress, which is what I'd rather frame it as, is we need to do much more in helping young people learn how to cope with stress. My frequent saying is, life's shit, you need to deal with it. It's not that bad, but for some people it is that bad. You know, we're talking about all the social circumstances that have changed, the huge poverty gap that's developed, and all the inherited discrimination that happens. So it has got worse for some people, and it's about how can we help young people, especially as they're developing, so that their future is going to be much more positive, to actually learn how to cope with that stress. And for me, it's around teaching skills to do that, rather than saying they're anxious.
Sorry, so you would start changing your language?
Yeah, and actually change the language of their parents and the teachers, and actually saying, yes, it's stressful, how can we help you deal with that stress?
So I really like the definition of what mental wellness is.
The WHO says it's a pervasive sense of well-being that uses up all your life. That's not word for word. But I think it's around how we all get down, we all worry, but it's around learning to deal with those down days and worry. And for me, the real secret is connection. So it's around relationships, you know, all the sleep, food, exercise stuff, obviously that's important, but it's really, it's relationship and how can we make connections. And I think there's more and more lonely people, certainly more and more lonely teenagers. They don't even talk, I think the average time that parents spend with their teenager these days is 11 minutes a day. So, you know, we need more time to actually communicate and link up.
Yeah, isn't the nub of that we are social apes? I mean, quite seriously, that we are social apes and deprived of society, we wilt. Yeah, I think that's... So that...
Yeah, Sue, your point about focusing on positive mental health, and the government needs to do, socio-political thing needs to do something about the poverty gap. But what if we could put much more of the resource for this sort of thing into schools? Because that's where all the young people are going to be for a significant amount of time as they're developing. So what if the whole positive mental health push went into schools?
Yeah, I think I'd like to distinguish between positivity and positive psychology and let's be happy all the time, and positive mental health in terms of maintaining mental health with connections. But yes, I totally agree. I'd love health and education to work much more closely. Certainly there's a program called Mana Aki at the moment, which is being trialled as a reaction to the earthquake situation. And that's great, because for me, you can't learn unless your brain's working okay, and your brain's being affected in terms of the way it's working by stress and all the other things that are happening. So yeah, definitely we should be working together much more effectively. Yeah, in terms of that maintenance.
I think though it's a really complicated question, and just doing things in schools is not as easy as it sounds. And doing some things like teaching kids about suicide and stuff seems to may even be harmful. So I think we have to have a culture of evaluation. We should try things and pilot things and then test whether they work. Not just say, oh, this seems like a good idea, let's do it, which is the traditional New Zealand way. You know, we suddenly say, let's do this, and then we have a comedian going all around telling people about suicide. I don't know why, no one says, is this useful or not, does it help? And I think we do need a more rigorous way of looking at things, because talking to kids can have all sorts of effects. Talking to them about drugs can make them curious about drugs rather than make them wish to avoid the drugs. So I agree with you that that's where it should be at that early stage, but I just think it has to be done very carefully and has to be evaluated very carefully as well.
As a former teacher, that's where teachers come in. Any half decent, not quarter decent teacher should be able to spot a depressed kid in their class and either help them or pass them on to someone for help. You really should. It's transparent. And teachers should be the first port of call. I hated it when schemes were put into school. They were imposed from outside. The kids didn't know the people involved. They didn't necessarily trust them. Whereas a competent teacher, most kids should have one teacher at least that they can actually go to, and that teacher should have their eyes open all the time. I firmly believe that. But that's just me. So.
I was wondering if you could talk to us about masking and the ability for young people and others to hide how they're really feeling, whether we actually can, or whether teachers can pick it up, whether professionals can pick it up, or whether there is more
Anybody?
Well, interesting enough, there's a study been in Scotland, sorry Joe, where they actually did get teachers, training teachers in fact, to look out for depression. It was a failure.
The fault was in the training. It was you not meddling.
So look, I'm coming from the perspective of seeing patients in an acute inpatient setting, usually when they've been admitted either because of significant risk or a crisis or whatever. And it can be incredibly difficult if someone is holding things in, and probably in a ward setting, observation and getting to know people, and that takes a few days to occur, and having a very experienced ward team around. Outside of a hospital setting, my God, that is such a complicated thing, and again, I think time and relationships are important, but you, as a teacher, that may also be a challenge.
The other thing to remember is that the way people sometimes mask how they're feeling is by drinking. And so they may feel reasonably seem sociable and happy when they're out, but other times they're not, of course.
Yes, sir.
What's the panel's view on emotional freedom techniques, or EFT? Is that any view that what's been discussed here? Or
Sorry, I can't quite hear you.
EFT? What's the panel's view on EFT?
EFT. Are you familiar with EFT?
Emotional freedom techniques. Emotional freedom techniques?
Emotional freedom techniques. Anyone have an opinion or knowledge of?
That sounds like something Roger would know.
No, I don't. So no, I don't have an opinion. I don't know whether anybody. We're obviously not very informed about those things.
Sorry, sir, we can't help you on that one. Yes, ma'am.
Related to that, maybe, I think it was Sue that said, no, sorry, it was like when you said psychosocial treatments. I didn't know what that meant.
Well, the lady's asking about psychosocial treatments.
It's really treatments that don't involve drugs to some degree, but it's a very broad term for, well, yeah, EFT I guess would be one. But again, I think there's a lot of goodwill and there's a lot of psychosocial treatment. We have to evaluate what works and what doesn't. And we don't have enough people to give psychosocial treatments to everyone who's distressed. So we're going to have to learn to do it in groups or through the internet. We have to look at novel ways of trying to do things. So I think just carrying on is not it. But yes, psychosocial treatments are essentially non-drug treatments and can involve all sorts of things.
So at group situations, we're learning a non-drug way to manage it.
Well, that would be one thing, yeah.
Yeah, would possibly be quite a good thing to deal with the amount of people.
That's right.
Talking about that, and like you said, Roger, working in Samoa and Cook Island, and then too, you said about diversity and thinking in novel ways, how much of a voice do you think there is for non-typical experts to mix things up? Like, you know, everyone on the panel is a certain demographic. You know, like how much power do you think other demographics have in changing things and bringing in different stuff?
Well, yeah, you're asking typical experts, aren't you? I'm a white male professor of psychiatry. You can't get more cliche than that. So I feel I'm not probably the person to comment, but I think there is evidence that having more patient involvement in treatment and more collaborative stuff may be a way forward. And certainly, it's interesting, in low and middle income countries, they have to have other models because they can't afford a model like this. So they have models where they use peers to help and where they just look at problem solving. They don't actually address the mental health symptoms, they address the problems and then measure to see whether the mental health symptoms get better. So it may be those countries that give us some new ideas where they simply don't have the resources to do what we think we should be doing. But yeah, I don't think I'm quite the person.
Which is one of the reasons why we're trying to get for young people a youth hub going with different people to help solve the problem in terms of employment or training or something to do or creative outlet, rather than focusing on doctors and nurses.
Thank you. Yes, sir.
As a leadership coach, I was very interested in Professor Blue's comments that we may be able to get people to adjust their own brain waves. Has anyone in the panel got some practical ideas on how to get there?
Okay. So did you catch up with David Nutt when he was here earlier in the year? So David Nutt's a psychiatrist in London, and he's famous for a number of things, but in the last couple of years he was behind a study giving psilocybin, so this is the active ingredient in magic mushrooms, to people with resistant depression. It got published in the Lancet Psychiatry. But it wasn't just, here, take this magic mushroom tablet and let's see how you are in a week. They looked at brain imaging, and one of the things they found in the brains of depressed people was an area that's called the default mode network. So this is a sort of state that your brain goes into when you're not really thinking about anything. It was massively overactive, and what the psilocybin did was it essentially took out the activity within that network. It may well be that some of these very fast-acting drugs may be acting to dissipate overactivity within malfunctioning networks or overactive networks. What we're doing with neurofeedback is is to isolate the network so you can put an EEG cap on, identify the waveforms that are associated with that network, and then give people a set of headphones. And as they're able to reduce the activity in that brain network, that's associated with an alter in tone in the headphones. So you can do the same things if you want to alter your heart rate or blood pressure by having a little finger cuff on and you can relax. Although many people have different ways of altering their brain networks, a very common one seems to be a sort of a Zen-like state where you try and empty your mind of everything. Perhaps 2/3 of people seem to be able to do it reasonably effectively. It takes a lot of rehearsal, so you might have to do daily treatments over 5 to 10 weeks to be able to do this in a way that you get enduring results. But again, this may be another non-drug way and non-psychotherapeutic way of altering network activity with a knock-on effect in particular symptoms.
We use a similar technique in people with autism who often feel very anxious for a lot of the time, and then when they get anxious, sometimes the bodily sensation of being anxious makes them feel even more anxious. So it's very easy to get into a very vicious cycle quickly, and our psychologists work with them using a similar biofeedback. I think it's based on skin properties of skin which relate to anxiety. They can learn to control their anxiety by getting feedback in a graphic form of what's happening to their bodily functions and learn to control it. It's quite a useful thing in some situations.
Lady at the back there, then get here.
What about transcendental meditation and mindfulness?
Roger, that's you again.
Yeah, I mean, it's a similar thing to what he was talking about. It's a way, if we can get individuals to learn strategies to manage their symptoms, that's clearly a better way than continuing to have to give them therapy. And again, I guess we have to look at ways of doing this. But like everything, unfortunately, when we have this sort of individualistic culture, that tends to be oversold, and you tend to get people who look to make money out of it, and you tend to get a whole lot of other issues. The principles are fine, but I'm always wary of the sales that come with it. So it's probably useful. In fact, it's almost certainly useful, but not as useful as some people say it is. And some people are better at it than others. I'm dreadful at mindfulness. I can never get my mind to any sort of way of being clear. So I guess it's not for me.
Anything that actually switches off your adrenaline, noradrenaline, cortisol production, which is your normal response to stress, anything that helps you switch that off is going to prevent all that ill health that we talked about in terms of adverse child experiences, because that's what kind of damages your body and your brain.
Let me hear.
Yeah, it was a similar question. It was meditation, mindfulness. I just wondered how many can they do?
Roger, I'm useless.
I've tried, but I can't.
I sort of pull limbs off trees and burn them, so which is fantastic.
No, I'm not a mindful person.
I walk the dog. I'm serious, walking the dog is often, if I'm feeling shitty, I take the dog out in the hills, and 15 minutes on the hills, the dog is really good, before drinking then. Then it's drinking, all right, for the rest of the day. So,
Can learning how to stress be formalised in a set of rules or aphorisms, and if so, that would reduce the need for hyper professionals to deal with something that's fairly fundamental. Is it possible? Is there a set of rules that go stressing it?
I think you can probably judge that by looking at the number of books on stress management and stress relief in an airplane bookshop. If it was that simple, there wouldn't be 50 books about it.
The trouble is you're also dealing with people who vary so much, and therefore an algorithm isn't going to do it because it doesn't take into account that amazing variance of different people.
I think you're getting a no, so I'm afraid. Yes, ma'am.
Was just
wondering if the panel, any of the panel would like to comment on the psychiatric effects of the Thai people, young people who have been carried.
I mean, the first thing I was going to say earlier was that I believe they used ketamine to anaesthetize them to get them out. But as far as the psychiatric effects, obviously there is potential that they're going to develop post-traumatic stress disorder type symptoms following that. But it may be that the whole group support, bonding effects may protect them from that. So I think it's yet to be seen.
They actually had a great story. They asked them how they chose who was going to go out of the tunnel first. I'm not sure it's true. It seems too good to be true. And said, oh, we got the ones who were closest to the mouth of the tunnel so they could cycle home and get us some food when we came out. And I thought, that's a pretty good communal way of looking at it. So maybe they're more hardy than we think.
I mean, my gut feeling is they're going to be just fine. And I don't know why I feel that, but I'm absolutely 100% certain of it. But what do I know?
But I thought maybe you were talking about, I thought it was amazing, the whole worldwide, it was almost like the whole world was willing them to get out. It was almost a spiritual experience rather than a mental health one.
I thought it was voyeuristic. But anyway, that's neither here nor there. Question back.
So you mentioned about brain alterations and childhood trauma. What kind of alterations could be observed and how are they reversed?
Well, at the moment, all we've got is MRI scans, and you can see blank areas, which should be lit up. But we need to learn much more about how the brain develops. There's so much to learn, just from the function through to the anatomy to how it all interacts, the neurotransmitters. There's a massive amount to learn. And if we can understand that better, then maybe we can actually do therapy better and prevention stuff better.
I think as well there's evidence that severe childhood trauma actually causes a little part of the brain which is important in memory and stress response to actually be smaller. So there's the suggestion it's actually either not developing to the same size or it's shriveled because of the severe stress that people are subject to. And you do get permanent resetting of the stress hormone axis of the cortisol that Sue has talked about. That whole system, which is quite a complex system, is reset by severe childhood trauma.
I think one of the things is that when people become teenagers, the amygdala, which is the bit that looks out for threat, actually gets bigger normally. That's part of being a teenager. So you're already kind of set up here. And if you've been damaged as a child, you're set up here. So it makes it much worse and harder to cope.
Yes, ma'am.
It's not actually that much higher. The whole of New Zealand is going up, and we did a number of studies looking at prescriptions of antidepressants didn't actually go up in Canterbury compared to other areas. What it seems to have happened, there was a small but and largely transient response. Now, it may be different with young children because that wasn't who we surveyed, but there's certainly the rest of New Zealand hasn't been protected from what I was saying. The statistics I was quoting are national statistics, and Canterbury's only a small part of that. So the earthquake doesn't explain why there's been this national increase in childhood distress. It was a really worrying thing. I saw in an American journal where they had some chart score of children's distress, which they do every year. They've been doing it since the 50s. And they were saying the mean score now, so the average score in 2015 was the same as the pathological cutoff was in 1952. So something funny is happening. Yeah, and I don't know what it is, frankly.
The ladies and gentlemen too much alone, said Orton in the 1930s, which I've always thought was a very astute commentary on misery. Yes, sir.
I'm Sam Johnson. I work with Robbie on we've matched young people who experience anxiety and depression up with basically a grandparent figure, and the matches hang out every week. My question is about, surprised that our conversation hasn't focused more on the changing nature of community and the simple things, and the focus a lot on the clinical solutions or clinical approaches to mental health. I'm just interested in the panel's view on how much you attribute our rise in mental health to the changing splitting communities and even changing the way of nuclear families.
There you go, pal.
Interestingly enough, we've just, we're doing, as I said, this survey of adverse child experience. Of the people we've talked to so far, 75% of the young people we see have a parent who's separated and remarried. So we've got these vast families, but they're not connected.
Yeah, I mean, I think you're right. Social connectedness does seem to be probably more important than we ever thought. And one of the ways to do it is to look at low and middle income countries or societies that have much more connection. I mean, if you look at Asian societies in New Zealand, we looked at people who got admitted or came into admitted, they were far lower among Asian New Zealanders than among the rest of the population. Interestingly, Asians usually group with Europeans, but if you separate them out, you see that they seem to be healthier, but the longer they stay in New Zealand, the more unhealthy they become. So, and the same in the United States, that each generation. Now, that's not the same for serious mental illness, but it's for sort of distress and stuff, and it does seem to help. And yeah, it's certainly apparent if you go and work in low and middle income countries. The problems are different, but the social connectedness is not one, and that seems to have real strengths in terms of levels of mental distress in the community.
Is the number that competitive Western capitalism is bad for us?
Definitely.
Well, I think it's bad for your mental health. Some people say it's good for other things, but I think certainly that's one of the things.
Because we couldn't afford mental health services without it.
I'd love to get community halls and community dances back, intergenerational.
Yeah, I'm sure it's a winner. I'll take 2 more questions. Hands up, the lady there and the lady there, and then we're going to have to cut it off, I'm afraid. Though there is the chance for the next hour after this to be social, to talk to people here, to talk to the panel individually, to get drinks and so on. I'll go on to the details of all that in just a second, but only 2 more questions because we then have to go on. So, you ma'am, and then one at the back there, yeah?
I'm old enough to remember 40 years ago, the WHO, World Health Organization, predicted what's happening now. It said that because we were all using our, this is really chemical, but we were all using our brain chemical messengers so much faster than what we make them every night. And they predicted what's happening now is going to happen from just, it's like a car. If you go from here to Invercargill at 100, you need so much petrol. If you go at 120, use more petrol. But we only get that petrol at night. And that may be updated for younger people. But remember, this is what's happening is what they said 40 years ago is going to happen.
Right. Okay, thank you.
So, would you call full-time daycare from 8 a.m. till 5 p.m. and youngsters from a very young age, would you call that an adverse childhood experience? And have there been any studies comparing?
We could actually look at that because the Dunedin cohort study has followed people up, and they can follow people up who've been in daycare, 100 hours a week, compared to those who haven't. So that'd be a really good question to ask the cohort study.
It's a fascinating question. Okay, ladies and gentlemen, let me just explain what's going to happen. People are going to sweep into here to clear the chairs, which means that you're going to have to, this will astonish you, stand. All right, but not just for one, but just so that you're aware. Simultaneously, those shutters will rise. There'll be free non-alcoholic drinks, purchasable alcoholic drinks. Food will enter. I can't guarantee it will all be instantaneous and simultaneous, but it's all going to happen within 5 minutes. That is free for one and all. And these people are not allowed to run away until they have answered every question you want. If you see any of them go over the door, let me know and I'll have them back in here. And so if you can... But first, we need to thank the panel for their expertise. Thank you very much. There we go. So, Jerome, if you could get the things happening and get on your feet, ladies and gentlemen, mill around, talk to each other, don't be alarmed, talk to the panel, and all the stuff like that.